and all dear friends, all my dear students, all friends and colleagues. So good evening all. I welcome you all for this our academic program. Today we have got two sessions. The first is the main talk by Dr. K.K. Mubarak. He is the principal of Wayanad Medical College. And the second session will be for the PG corner by Trivandrum Medical College students, Dr. Rakhi and Dr. Rahul Dev. And I welcome you all once again. And now we can go on to our academic sessions directly, because as I am not seeing our national president to speak a few words. Is he available now?
Sir is not available, ma'am.
No. So now we can go on to directly to our academic session. Okay.
Thank you, madam.
Okay.
Thank you, madam. It's a pleasure to introduce Dr. K.K. Mubarak. In fact, sir doesn't need any introduction. He's a well-known faculty in most of the conferences in India. And he's been an examiner for both the DA, MD, and critical care medicine for the last 15 years. He is an alumni of Calicut Government Medical College and Kasturba Medical College, where he did his MD. And he has got 20 publications to his credit. And at present, he is a professor and a principal at Government Medical College, Wayanad. And he has been a long-term professor and HOD of Government Medical College, Calicut and Trichy. Over to you, sir.
Good evening. Am I audible?
Yes.
Yes, sir, you are audible.
Okay.
Slide also visible. Clear.
Okay. So, good evening to all. First of all, let me express my sincere gratitude to Kerala ISA branch, Dr. Shamshad, Dr. Paul Raphael. National President Dr. Venkatagiri is not here. I thank him. And Dr. Rajesh for inviting me for this session. And our online programs have been started with the onset of COVID, and now the COVID is coming down, and we have been permitted for physical meetings also. So whether I think we also will, and the ISA has lifted the ban, it seems, for the physical meetings. So I think we'll gradually move on to physical meetings also, but this sort of online meeting has proved to be advantageous for the postgraduate as well as consultants, because they can attend at their own residence or workplace or wherever it is. So this way, I think this sort of program will continue even if the online or this physical programs are being incorporated after this, because the COVID has come down. Okay. So the topic I'm going to talk is Neuraxial blockade for obstetric analgesia, an update. So I'm not going to the details of obstetric analgesia, the different methods, different types, and also I'm not going to the finer details of Neuraxial blockade. I'm only focusing on certain recent updates and updates on this topic, because many topics, many a time when we have an obstetric analgesia, we take the major share for the initial topics, and when it comes to the this Neuraxial blockade, the time gets over. So I thought I'll concentrate on Neuraxial blockade, and that too on the recent aspects and certain updates, and any doubts and clarifications we can take up towards the end. So I plan my talk for about 45 minutes to maximum 1 hour. And so now it is almost 6:15. So we'll wind up the session by 7. That's my plan. So moving to the topic as such. So the topic is Neuraxial blockade for obstetric analgesia, an update. So just a few things about the history of obstetric analgesia. Obstetric analgesia was initially given by the Scottish obstetrician Sir James Young Simpson on January 19, 1847. and it was done by inhalation anesthesia by administering chloroform. That was in history the first obstetric analgesia. Then later, other inhalation agents were used for obstetric analgesia, like nitrous oxide, ether, and other inhalation agents. And all of you might have heard the John Snow, Dr. John Snow, as an anesthesiologist, has administered obstetric analgesia by inhalation of chloroform to Queen Victoria in 1853. That was for her 8th delivery of Prince Leopold. So a woman who had been delivered without analgesia and later given analgesia during her subsequent deliveries, really they will appreciate the benefit of obstetric, the pain relief for labor. And the statement by the princess was, it was the blessed chloroform, soothing, quieting, and delightful beyond measure. So she appreciated well because it was her 8th delivery, and later John Snow has administered the same anesthetic for her, an analgesia for her next delivery, that is in 1857, that is 10th delivery or so, for Princess Beatrice also. So this was very well known in the history of obstetric analgesia. So coming to our topic of neuraxial anesthesia and analgesia in obstetrics, Oscar Kreis, the obstetrician, was the first person who had given neuraxial blockade for obstetric analgesia. Previously, all were inhalation analgesia with ether, chloroform, and other agents. And he had given spinal anesthesia in 6 parturients for labor pain relief, for which the anesthetic drug used was cocaine. Cocaine was the anesthetic agent for use for spinal anesthesia during those periods. And this was the first documented neuraxial anesthesia in obstetrics. In 1930, the pain pathways of labor were described by Epidural, and the continuous caudal analgesia, that was the first, and that it was started practicing for labor from 1942 onwards. It went on till so many years, but recently it has been withdrawn and not practiced much because of the difficulty because it is an infected area, the problem along with the labor, and it is not being practiced nowadays, but it is still mentioned as caudal analgesia, one of the neuraxial blockade for labor analgesia. Then the lumbar and epidural analgesia, which is the commonest one practiced till recently, has come to practice from the early 1960s. And now various types of epidural analgesia, the continuous epidural analgesia, combined spinal epidural analgesia, are the commonly used, most effective, and still practiced method of obstetric analgesia. Then the invention of lidocaine in 1950 was a major advance, especially for spinal anesthesia and also for epidural analgesia. In 1960s, the supine hypotensive syndrome was described as the major problem in obstetric patients when given analgesia or anesthesia, when given neuraxial blockade. So the importance of uterine displacement by simple positioning was found out very effective, and that marked the advancement in obstetric anesthesia and analgesia, then reduced the morbidity and mortality in obstetric anesthesia. And in 1946, Mendelssohn has described the acid aspiration syndrome, so which is very common in obstetric population. So patients plan for obstetric anesthesia or analgesia should be well prepared against this acid aspiration syndrome. So just a brief description about the labor pain pathways. All of you know the first stage and the second stage of the labor pain are different. The first stage is mainly a visceral pain due to the dilatation of cervix and the lower uterine segments with uterine contraction, and it is referred to T11 and to T12 in early stages, and later spreads upwards and downwards to T10 and L1. So this has to be tackled by during the first stage, and when the labor advances, when it comes to second stage, the vaginal dilatation and all will cause pain. It is a somatic pain which involves the dermatomes S2, 3-4 segments. So the first stage pain and second stage pain are entirely different, and that it requires different targets by the anesthesiologist to effect both types of both pain during the first stage and second stage. So the second stage pain is due to stretching, and it is conducted through the thick myelinated fibers of S2, S4 nerve roots. So why do you want to have pain relief? The primary role of a doctor and more of an anesthesiologist is relief of pain, and labor pain is not an exemption to it. So as a humanitarian, as a doctor, one should relieve pain, whether it is labor pain or not. And the pain is very unpleasant, and every person want to get rid of pain. And when it comes to labor, apart from the humanitarian and the other effects of pain, the pain itself has got problems in both the mother and the fetus, because of the pain-induced catecholamine release in the mother will increase the heart rate. It contracts the uterine blood vessels. It causes maternal pain, hyperventilation, and hypocapnia, which further constrict the uterine vessels, and it causes decreased ventilatory drive between contractions, and there is which causes a leftward shift of the oxygen dissociation curve of the mother, compromising the oxygen supply to the fetus, and which can add or cause a fetal hypoxemia and metabolic acidosis, which can all cause morbidity in the fetus and even in the mother. So the right pain relief for labor analgesia in the right time will benefit the mother, and it is medically indicated to get rid of these problems. So with labor analgesia, the relieving pain and suffering of the mother make the delivery safer for the mother as well as the baby, and decrease the fetal acidosis. The premature bearing down without analgesia can cause birth canal trauma and birth injuries, and uses of parenteral opioids too much can cause respiratory depression both in the mother as well as in the baby. So labor analgesia, neuraxial analgesia is advantageous definitely for the mother and fetus. So the pain relief in labor may improve the course of labor and blunts the adverse effect of maternal catecholamines. It improves the uteroplacental perfusion, and there is lesser incidence of psychological problems like postpartum depression and persistent postpartum pain in mothers who had been receiving labor analgesia. So coming to the analgesia, what is the indication for giving labor analgesia? Just the maternal request for pain relief during labor is an indication for giving labor analgesia. And the type and method has to be discussed with the patient, obstetrician, by the anesthesiologist and planned properly. And it can be initiated at any stage of labor, the first stage, second stage, or third stage. But as early as possible, it has to be initiated to get the maximum benefit of pain relief to the mother. Suppose there is a delay in initiating, one should not delay the pain relief because it should give the mother the proper pain relief. And as told earlier, the T10 to L1 for the first stage and S2 to S4 for the second stage is needed for the proper pain relief. And multiparous patients require a rapid onset of block, which I will come later. So we have got so many. We'll just go through the different methods of labor analgesia available. I'm not going to details. We have got non-pharmacological as well as pharmacological methods. Describe the non-pharmacological are the psychological preparation, hypnosis, and all the physical methods using TENS, acupuncture, and all those things. Then coming to pharmacological methods, initially it was mainly used by inhalation analgesia by using chloroform and all as in the history. And later Antonox, the mixture of nitrous oxide and oxygen, sevoflurane mixtures are all given for pharmacological pain relief by inhalation. Then ketamine is a commonly given intravenous anesthetic agent in small doses for labor analgesia. It is even prescribed or given by the obstetrician under close supervision. And systemic analgesics, various pethidine, morphine, fentanyl are given by intermittent or boluses or patient control analgesia by different methods. These are the pharmacological methods. Then coming to the regional blocks. The regional blocks may be neuraxial blockades and non-neuraxial blockades. The commonly practiced and the most effective methods are the neuraxial blocks, which we are going to discuss in detail. The common methods used now are the epidural, the combined spinal epidural, and the spinal methods, which I will come one by one. And as I told earlier, the caudal neuraxial blockade, it is not, though it was used and described in obstetrics, it has gone out of practice. And other non-neuraxial blockades like paracervical blocks, pudendal blocks are also practiced mainly by the obstetricians or even anesthesiologists in the later stage of labor, or for any supplementation of neuraxial blockade in ineffective cases, or used when the anesthesiology service is not available for giving a neuraxial blockade. So these are the various methods used. So coming to the neuraxial analgesia for labor and delivery. These are the most effective and commonly used methods for labor analgesia, which provides excellent analgesia with minimal risk to the mother and fetus, provided it is done in a proper way by a trained anesthesiologist with all facilities for resuscitation of the baby and mother. So coming to the modern neuraxial anesthesia, as I told, the epidural analgesia came in the practice in the 1960s. Later, the invention of bupivacaine in 1970s, which is extensively used in obstetric analgesia. Now ropivacaine has come. It is also being used for obstetric analgesia. The use of neuraxial opioids started in 1980s, which added to the efficacy of the various methods like of bupivacaine or lignocaine. And the advent of equipments for patient control analgesia and the newer combined spinal epidural sets and needles, the pencil point spinal needles. These are all advantages or the milestones which improve the benefits and the techniques and the safety of neuraxial analgesia for the obstetric patients. So it all about the indication. What are the contraindications for neuraxial labor block analgesia? Absolute contraindications are very rare, and the risks and benefits to be considered on individual basis. As I told, when a mother asks for labor analgesia, and if she accepts for a neuraxial blockade, you can definitely give a neuraxial blockade, unless there are medical contraindication like local infection or coagulopathy or any other problems which contraindicate a spinal or epidural puncture, like a raised intracranial tension or like uncontrolled seizures. Apart from this, there are no absolute contraindications, and most commonly practiced methods are regional neuraxial blockade for labor analgesia. So early neuraxial analgesia is advised in patients with high chance of going for an emergency cesarean section, or in patients whom the administration of general anesthesia is difficult or risky. So this includes the twin gestations, preeclampsia, vaginal birth after delivery. So these patients may go for an emergency cesarean section at any time. And if you have an epidural or a combined spinal epidural working, at any time you can immediately convert into a surgical anesthesia and go for surgical delivery, cesarean section. And in patients, in obese patients, or in patient difficult airway, or patients who gives or history, family history or a previous history, such as history of malignant hyperthermia, where drugs like succinylcholine are contraindicated. These patients, you establish a neuraxial blockade early, so that you are comfortable that you need not interfere with the airway in an emergency situation, and you can, in case the patient goes for an emergency section, you can easily convert into an anesthesia through the epidural catheter. So these are the advantages. So the currently used techniques for neuraxial analgesia for labor are continuous epidural, and then combined spinal epidural, then dural puncture epidural, single shot epidural and continuous single spinal techniques, which comes a single shot spinal or continuous spinal. So among these, the first and second are the commonly used techniques. I'll come to this one by one. The choosing of the neuraxial drug is individualized to each patient and the experience of the anesthesiologist and availability of the drugs. So the aim should be to provide adequate pain relief with minimal motor or without a motor blockade, so that the ability to participate the mother to push the baby out should not be affected, and an unnecessary intervention of instrumentation or surgical section has to be avoided by using, because one should not blame the obstetric analgesia provider to be the cause of a surgical anesthesia. And all care should be taken to avoid maternal hypotension by carefully titrating the drug and providing lateral tilt of the uterus by asking the mother to lie on the side, or in minimal blockade they can even sit or walk. And one should use minimal drugs to avoid the placental transfer of drugs, because excess of the accidental injection of drug into the intravenous epidural venous plexuses, especially with opioids, can cause maternal fetal depression. And always be prepared and look for systemic toxicity of local anesthetic agent, the last. And one should have all the facilities to resuscitate the patient in case an accidental intravascular injection occurs, or an unanticipated high spinal or a total spinal, but due to an accidental undetected intrathecal migration or injection of an epidural catheter, or a total spinal blockade, or some patient maybe due to some reasons suppose you administer the drug during an uterine contraction, there is maybe chance of the drug going to a higher level causing a high blockade. So one should be able to resuscitate these problems to provide safety of the mother as well as the fetus. So coming to the preparation and of this neuraxial blockade, one should have a good pre-anesthesia evaluation, including the obstetric history, anesthetic history, and medical history, with a detailed physical examinations, looking at the vital signs, cardiopulmonary examination, the airway and the spine. And always remember, whenever you are giving a neuraxial blockade, you should be able to take out the care of the airway at any time in an emergency. Like an accidental intravenous injection can cause a convulsion, or a high spinal, total spinal. So any patient who is being given obstetric analgesia or anesthesia, one should take maximum precautions. That doesn't mean that all the patient needs, but all the facilities and equipment, especially if you anticipate a difficult airway, you should have a difficult airway cart and the expertise available at your hand whenever you institute obstetric analgesia also. Then coming to laboratory evaluation. For a healthy parturian, the routine lab investigations other than the routine done by the obstetricians are not required just for providing obstetric analgesia. And in those with a high risk, like hypertensive disorder, pregnancy, or other conditions may require a platelet count. And at those with a risk of bleeding and all, cross-match blood should be available. But as such, for obstetric analgesia alone, detailed investigations are not required in healthy patients. And one should always get an informed consent before starting obstetric analgesia. And it is always better to have this discussion with the obstetrician as well as the mother or even the couple during the antenatal visits regarding their plan for obstetric analgesia and the different options. They can be given pamphlets to read, or they may be asked to refer the website, the internet and all. They will be coming. So, and one should discuss with them the anesthesiologist's role, and the risks and benefits of different options of analgesia should be given to the patient. And if a patient opts for some techniques, we can, and suppose a patient does not want to have a regional blockade at all, we can talk to them, and if they are not willing, we have to look for other options like a parenteral or other method or inhalation, or you can, or if, and one should not guarantee 100% pain relief, because any methods can have partial action or failed action, and you may have to go for an alternative method. Suppose you give an epidural, it may be a patchy epidural, or a unilateral block may be there. In that case, you may have to supplement by parenteral opioids. So failure chances and alternate options also should be told to the couples, because in case one technique fails for patient pain relief, you may have to use an parenteral or inhalation agents like that. And has to be discussed with the couple and as well as the obstetricians. And there is a higher chance of instrumentation, especially the outlet forceps when obstetric analgesia is incorporated. So that also should be discussed with the patient as well as obstetrician. And the services of obstetrician should be available throughout the obstetric analgesia, as well as the pediatrician or the neonatologist, and the facilities for maternal as well as the neonatal resuscitation should be available, and all this should be documented before instituting labor analgesia. So preparation, we should have, after getting informed consent, that we should set up the theater, or in a labor suite, you can have a separate room for space for instituting an obstetric analgesia, because one need not shift the patient to the operation theater to put the obstetric, the epidural or the analgesic, because it may take so many hours. So you have it is better to have a separate area in the labor suite to institute the labor analgesia. Or if not there, you may have to go to the operation theater if facilities are not there, have the epidural, and then bring back the patient to the labor suite. That's also possible. Then coagulation status, as I told, has to be checked. Equipments, the anesthesia, resuscitation equipments, the airway equipments, all should be checked and kept working condition, and also the necessary help. And it is very important and legally important also to have lipid emulsions, 20%, to treat in case of any unanticipated local anesthetic toxicity. And aspiration prophylaxis may be given to the mother. And it is not advised to keep them fasting, because it may take so many hours for the sometimes some preemies may take hours for labor, so we can't ask them to fast. And having liquid oral sips, fruit juices are allowable during a labor analgesia. So pre-procedure, so now ultrasound has come to all the nerve blocks and blockades, and neuraxial blockade is not an exemption to it. So in case there is any difficult in obese patients, or difficult anatomical landmarks, or scoliosis patients, or patients who had previous spine surgeries, those experienced in ultrasound sonology may use this for obstetric analgesia also, for getting the neuraxial blockades. And for building the proficiency also, as a teaching also, one can use a neuraxial blockade to, because nowadays and as time goes on, the use of ultrasound is becoming routine practice in anesthesiology. So I'm not going to the details of this neuraxial, this is the neuraxial ultrasound, the bat wing sign and all those things. So then coming to the positioning of the patient, the sitting position, lateral position is mostly used for giving the neuraxial blockade, but sitting position may be adopted in obese patients or in those with difficult bony landmarks. But the lateral position, patient comfort is more, less chance of assistance is needed, and especially when there is advanced cervical dilatation, when the patient may not be able to sit in advanced labor. Then when there is risk of cord prolapse, you cannot make the patient sit up, because the risk is more, and it facilitates lateral position facilitates fetal heart monitoring and less chance of intravascular catheter. But the problem in lateral position is, once you give the anesthetic in lateral position, you can give the half of the drug in the lateral position in which you do the puncture, and it is better to turn the patient after some time to the other side and give the rest of the drug. Otherwise, if you give the whole drug in one lateral position, there is, though it is not described in textbooks and all, in practical experience, it produces a preferential unilateral blockade, and that may be a reason for partial failure. And also, you can give the drug in a lateral position for some time. Epidural, I'm talking about epidural, or have the drug wait for some time and then turn the patient to the other side and give the rest of the drug. And monitoring, the routine monitors the heart rate, pulse oximetry, saturation, and blood pressure has to be monitored in all patients with obstetric analgesia. And also the fetal heart rate monitoring should be done every 5 minutes. And during maintenance, it can be extended, maybe BP, maybe every 30 minutes, or more frequently if there is hypotension or abnormal fetal heart racings. And one should also monitor the pain control, the adequacy of pain, maternal satisfaction, the pain relief. Whether there is any motor function, you should ask the patient to move, ensure that there is no motor blockade, and in case there is any motor blockade, the further top-up should be delayed, or dilute solution should be only used. And check the sensory level, especially whether during the first stage and second stage, as I told, the requirement of sensory level is different. So towards the second stage, you may make the patient sit up and give the top-up dose so that the drug will act more on the dependent part, usually the sacral roots. And coming to the epidural technique. And most of the things I have spoken so far is related to the epidural, because this is the most commonly used in our country. But in Western countries, the combined spinal epidural is said to be commonly used. So the epidural puncture is done below the L2-3 interspace. The catheter is passed, then secure catheter. I need not explain. And you can give the catheter is fixed 2 to 3 centimeters inside the epidural space. Okay. As per the availability, you can have an infusion pump or a PCA pump, or you can choose for intermittent injections, especially as per the available situation in the center. And there's so many controversies during exams regarding epidural test dose. So what we recommend is 3 ml for test. Though when we are using bupivacaine for test dose, it's better to use lignocaine, because it will provide an early recognition of motor blockade if injected accidentally to the subarachnoid space. So a 3 ml lignocaine with 1.5% for subarachnoid block, and along with 5 microgram per ml of epinephrine is added to detect whether there is any intravascular accidental injection. And a motor block within 3 to 5 minutes after this mixture indicates a subarachnoid block. And in that case, you have to pull the catheter or take as a subarachnoid method, I will tell later, or you have to do a repeat puncture for if you're planning for an epidural. And in case it is a difficult epidural, you can go for a subarachnoid block even with a lower dosage of the drug. That's a dural puncture epidural. Then an increase in the maternal heart rate of 20% or more in 10 to 25 minutes suggests an intravascular accidental injection. So, and that also should be, in that case also, one should aspirate, and if you suspect intravascular, you have to take out the catheter and do a repeat puncture, and the drug will not act also. There is chance of convulsions if you give and other complications during subsequent doses. And never give the drug during a uterine contraction, because one thing, the pain induced by the contraction itself will there will be a maternal heart rate increase, which you may misinterpret as a intravascular injection, and the pain also, and there is chance of the high level of the blockade. And epinephrine can cause hypertension and reduce the uteroplacental perfusion. And whatever test dose, no test dose is 100% effective. And whatever test dose you have given during each injection, you have to anticipate an accidental or an unintentional migration of catheter or injection of drug into subarachnoid space or an intravascular compartment, and ensure and closely monitor after each bolus of injection. And if it is a continuous infusion also, you have to frequently monitor for any catheter migration, because the patient can move, or in a walking epidural, the catheter can get misplaced. So one should be very careful in giving the epidural dose. And the epidural analgesic drugs, the commonly used drugs are now the bupivacaine or ropivacaine are the commonly used drugs. A low volume of a higher concentration drug or a high volume of a lower concentration drugs. These are all dependent upon the individual preferences and experience with or without opioids. The commonly used combination is a 0.625% of bupivacaine with 2 microgram per ml of fentanyl, or of 10 ml usually suffices, but we want to titrate very well and require to individualize the patient to give the minimum required. And this applies both for bolus as well as infusion. And more concentrated solution or a top up with the patient sitting position may required for a sacral block towards the second stage or for an assisted vaginal delivery. So the commonly used drugs are bupivacaine and ropivacaine. Now both are homologous, long-acting amides, local anesthetics. The analgesic potency of ropivacaine is 60% of bupivacaine. Cardiotoxicity, both are said to be equal. In this conflicting views are there, but it is not of much importance because for labor we are not giving anesthetic dose. So with the small dose of analgesic dose of lower concentration, the chance of cardiotoxicity is very minimal, and the efficacy, the maternal satisfaction, all onset of analgesia are all comparable. Bupivacaine 0.625% or ropivacaine 0.08% is usually given in combination with the fentanyl or sufentanil for better analgesia. Lignocaine is not used commonly as a primary analgesia for labor analgesia, but if there is patchy block or one can give a trial of lignocaine in a smaller dose, or if the labor is advanced and the lignocaine produces a more denser blockade, or you need a sacral blockade only. In that case, in such cases, rare cases, lignocaine can be used in a concentration of 1% for second stage or instrumental delivery. Then 2-chlorprocaine is an ester local anesthetic. It's also of rapid onset of action, of short duration of action. Some centers we have it's available. It is recommended, and one can use it for rapid extension of labor analgesia for instrumental delivery or even for urgent cesarean section. But there is a reports that chlorprocaine may reduce the efficacy of epidurally administered bupivacaine and opioids during subsequent injections. Now coming to use of epidural opioids. Epidural opioids alone will not provide sufficient analgesia for labor or cesarean section, and it is often combined with local anesthetic because it has got a synergistic action with rapid onset and provides better analgesia. The commonly used opioids are lipid-soluble opioids, fentanyl or sufentanil, along with the local anesthetic bupivacaine or ropivacaine. Regarding epidural epinephrine, epinephrine is not used for labor epidural analgesia. Only for test dose it is recommended because it will increase the maternal heart rate and blood pressure. But if the patient goes for a cesarean section, you administer lignocaine, you can add an epinephrine for a quicker action and a prolonged action, and it can increase the motor blockade and has a relaxant effect on uterus. And other epidural adjuvant drugs used are clonidine, neostigmine, dexmedetomidine. These are all used also for epidural analgesia, but not routinely used. But individual cases, individual centers may use for studies and all. And these are all has got varying effects on the combination of with local anesthetics, which can be tried on individual basis. So, how to initiate the epidural analgesia? As I told, once the catheter is positioned after negative aspiration, inject in 5 ml increments. That's the commonly administered dose of 0.625% bupivacaine or 0.08% ropivacaine with or without fentanyl or sufentanil. And as I told, aspirate prior to every injection and treat every bolus as a test dose, because there is chance that it may cause a unintentional intravascular or intrathecal injection. And BP heart rate has to be monitored till stable. Never forget to assess the fetal heart rate, because delivery and accidental injection or obstetric cause may be there for fetal heart rate abnormalities, which has to be detected early, and obstetrician availability should be ensured always. Maintain uterine displacement, and if there is irregular block or inadequate analgesia, you can supplement a top-up dose in a different position, or you may change the drug, or in case of inadequate analgesia, you may have to do a repeat catheterized puncture, or a different type of analgesia like a subarachnoid block or a parenteral drug or whatever it is. So after initiation, the maintenance of epidural is either continuous injection infusion or intermittent injection as per the plan of the center, and it is better to have a continuous infusion with an infusion pump. And often the same drug used to initiate the block maybe is the drug given through the infusion pump, and bolus drug is given for any breakthrough pain, and always titrate analgesia to maintain the expulsive efforts of the mother and never produce excessive motor blockade, which may land up in a cesarean section or a fetal distress. So continuous epidural infusion reduces the clinicians or the obstetric nurses workload and decreases the fluctuations in pain, because the patient gets a steady level, and it produces greater patient satisfaction and reduces the risks of local anesthetic toxicity because of slow injection, but the rate should be titrated, and it causes less hemodynamic instability, but it does not eliminate motor blockade or rescue boluses or even local anesthetic toxicity, but one should ensure it is in the proper position and the dose is proper, and monitoring should not be avoided in these patients on epidural infusion. And the clinician top-ups, one should assess the pain frequently, and you should not have the pain to be reported by patient to give a top-up. Before you have to assess by the uterine contraction, the facial expression of the patient and all, and always ask the patient or the nurse to palpate the uterus over the abdomen, and the contraction of the uterus can be sensed by palpation, and the mother should be asked to strain along with the contraction and not in between. So otherwise the mother will get exhausted and may land up in instrumental delivery or cesarean section. The sensor level should be checked, especially during the first stage and second stage differently, and the catheter position has to be reassessed during every top-ups. And suppose the patient has a unilateral pain, the unilateral pain may be due to epidural, anatomical problems in the epidural space due to any septa or so, or as I previously told you, give injection on one side and make the patient to lie on that side for longer time. The non-dependent side may have a lesser analgesia. So in that case, you may take the patient to the other side and give the top-up, or give a sitting, you ask the patient to sit up, or give other drugs like lignocaine, smaller doses. In case you have any suspicion regarding the catheter position, you may withdraw the catheter for 1 centimeter or so and try to inject again, aspirate, see. And in case the pain persists, you may have to replace the epidural catheter or go for an alternative options. So if there is persistent pain even after repeated boluses, consider early replacement of the catheter. And once the epidural needs more than 2 boluses, they are likely to go for surgical anesthesia. And in such cases, the combined spinal epidural or a dural puncture epidural, that will come later, will improve analgesia. So walking epidural is commonly used for asked for exams and also some practice. Walking epidural is you give a patient the anesthesia, analgesia in such a smaller dose to get relief of the pain, but no motor blockade, so that the patient can walk about. Now the spouse, the husband can be with the mother and with the wife and help her to walk around. That will improve the patient outcome as well as the fetal outcome. And for this, the sensation has to be retained and the contraction has to be sensed by the mother when she has to lie down and strain. And this facilitates pushing the baby out in the second stage. Coming to patient control analgesia, the infusion, I told the continuous infusion, but patient control analgesia, the patient can, against the background infusion of the epidural, the patient can self-administer boluses of epidural, in which the clinician has to set out the lockout intervals and you all know those things. And it should not cause an overdosage of local anesthetic and cause a motor blockade. But it needs a maternal participation, and it provides better acceptance of mother and improved analgesia and lesser clinician interventions. The patient control epidural analgesia. Now we have computer integrated patient control epidural analgesia. That is so this is the computer integrated set in which the clinician can set the background infusion rate based on the requirements of the previous hour requirements, because the individual requirements may vary. So the last hour, how much the patient have required an analgesic, that will be taken to the next hour, and the computer will give the required dosage depending upon the individual patient's consumption. This is the computer integrated patient control analgesia, which is being used now. Then another technique is program intermittent epidural boluses. That is, without patient participation, the boluses are, the clinician will predetermine the boluses at the predetermined intervals, and with the special equipment, the epidural drug is given at a high injecting pressure, so that there is a greater spread in the epidural space, which produces a better or improved analgesia and reduced breakthrough pain. Lesser of this has got lesser motor weakness and better patient acceptability. So with this, there is chance of inadvertent catheter migration, and there is a risk of total spinal or high spinal block, and one should be very alert, cautious in during these methods. And this can be combined. These techniques can be combined and programmed, but it has to be individualized by the clinicians and the patient acceptability, and never give produce a motor blockade. So now I come to the next technique, the combined spinal epidural technique. So the combined spinal epidural technique, that puncture as in the epidural, it is done below the L2-3 interspace, and intrathecal injection is given for the rapid onset of spinal analgesia, and epidural is used for maintaining the further maintenance of analgesia or any surgical anesthesia if required. So it is given by a special needle through needle technique, or an epidural in one space, or with a spinal needle with the other space. And the dural puncture and the dural puncture is made to give the subarachnoid drug for a quicker action, and this is especially useful in later stage of delivery. And even a walking epidural are done with combined spinal epidural, but one should be very careful not to have a higher dose of intrathecal drugs, because it can cause a more of a motor blockade and lesser participation of the mother in delivery. The combined spinal epidural needles are available. Standard epidural spinal needle can be used, or a double lumen epidural needle with a hole for spinal needle. And all special equipment, CSE equipments are there for obstetric analgesia also. So the combined spinal epidural, all of you know, the spinal needle is in the subarachnoid space, and the epidural catheter is in the epidural space. Initially, we give a bolus of subarachnoid for a quick denser blockade, and then the epidural is maintained for a maintenance of analgesia. And in case the patient goes for a cesarean delivery or instrumentation, you can supplement the analgesia through the epidural. The combined spinal CSE drug, again the local anesthetic bupivacaine or ropivacaine with fentanyl or sufentanil is used. The concentration used has to be a little reduced because when there is a thecal puncture, there is more chance of a higher blockade. So one has to titrate, and you cannot go for a textbook dictated dosage. One has to start with a smaller dose, titrate. These doses are just for guidelines, but you have to start with a very smaller dose, ensure analgesia and maintain analgesia without a motor blockade. And if you're planning for a walking epidural, the motor blockade should be very minimal for patient participation. And always remember, when there is a thecal puncture, there is a chance of subarachnoid blockade and higher chance of motor blockade, and as well as chance of hypotension, fetal bradycardia, and all those things. Then coming to the spinal techniques. Spinal techniques are less used, but described nowadays maybe in later stages of delivery when to initiate, or when the epidural is difficult, or when you make an accidental dural puncture during an epidural. In that case, you can go for either through the spinal as single shot spinal, or you can thread the epidural catheter into subarachnoid space and give a reduced dose and make it as continuous spinal through the epidural. So these are all individualized techniques, but described nowadays. So the single shot spinal is rarely used. I'll come to it. Right, it has got the spinal techniques has got rapid onset of analgesia, and symmetric analgesia, and better sacral analgesia, but the duration of action is limited when a single shot spinal. In that case, if there is prolongation, you have to give other methods of analgesia. So this can be done even after an accidental dural. Suppose you do an epidural puncture and make an accidental dural puncture. Don't get panic. You can reduce the dose and give it either. You can plan it as the clinical condition, either to a single shot spinal. You can give a spinal drug, or catheterize, put an epidural catheter into that space and treat it as a continuous spinal. That is also possible. So single shot spinal analgesia, the indications are for multiparous parturian in late labor, or in a difficult epidural, or a difficult spinal. And if you find it a difficult spinal, you can use a spinal 2He needle as an introducer and do a spinal, or we have got spinal neuraxial ultrasound, neuraxial spinal needles with introducers are also available when you can make a smaller dural puncture. But the chance of post-spinal headache is more in obstetrics, so the chance is there. So as far as possible, use a smaller needle, and if available, you can use an introducer needle through which you can do a smaller thecal puncture. Then continuous spinal analgesia is putting the catheter into the intrathecal space. So it produces rapid onset of dense symmetric analgesia, can extend analgesia and convert to a surgical anesthesia, but it is rarely the first choice because it will produce a dense blockade, and it may end up in an anesthesia rather than analgesia, and make an urgent operated delivery necessary. There is a high chance of post-dural puncture headache and rare chance of Coda Equina syndrome. But in difficult epidural, as in a spinal surgery patient, or occurring in an accidental dural puncture, but it should not be an accident. Unknowingly, it should not go to a spinal and give the epidural drug in the intrathecal space. That will definitely land up in a high spinal or total spinal. Knowing that it is in the epidural space, you give a smaller dose of drug as a continuous spinal anesthetic, it will work, and it will be safe in hands of experienced. And in such cases, you have to get should have an experienced assistant also, or expert advice available also. So there are continuous spinal equipment. You can use an 17 or 18 gauge epidural needle and an epidural catheter to make a continuous spinal with a dural puncture with the epidural needle and go for a epidural catheter. because the using of a micro spinal catheter and micro puncture are technically difficult, and it has been previously banned in US FDA because of these problems. But there is more technical difficulty in catheter failure. But now again, the spinal micro catheter has become available, but we have not come across such catheters. And the chance of failure is more, technical difficulties there, and injection of the drug is also difficult to such a micro catheter. So it is, though it is described, it is not routinely practiced except in accidental dural punctures. Then intrathecal analgesia, the long-acting drugs, the bupivacaine and ropivacaine, usually combined with lipid-soluble opioids, fentanyl or sufentanil in a smaller dosage. And it always remember, it is the lower dosage. The dosage is very low, about 1/10 of an epidural when it comes to an intrathecal drugs. And the chance of pruritus and fetal bradycardia, as with when combined with opioids, are there with intrathecal also. And once you have an intrathecal catheter, always remember, never inject an epidural dose through it. Keep separate labels, danger marks that this catheter is intrathecal and spinal, and epidural dosage should not be administered, and accidentally the intravenous drugs also should not be administered. And no demand bolus or program bolus or patient bolus is allowed in subarachnoid catheter continuous spinal techniques. So these are the doses advised: bupivacaine, ropivacaine with fentanyl. The next is the described recently is the dural puncture epidural analgesia. That is like the combined spinal epidural. The dura is punctured deliberately, as in CSC and combined spinal epidural. The spinal needle is removed to have the CSF flow. Then through that, epidural catheter is introduced. So this is done for a faster onset of better analgesia, and it gives a more extensive caudal spread, especially for sacral analgesia. Now coming to the second stage, or the late sacral pain, when the cervix is fully dilated. So you have to make the patient sit down or give an additional top up, because the first stage drug may not be effective for control of the second stage pain or sacral pain. And if the epidural is not put in a very higher level, you may have to consider different options, or you can ask, you may have to supplement with other methods like narcotics, or even in a single shot spinal if required, or if the epidural catheter is not functioning properly. And top up for sacral pain, you may have to use a higher bolus, more concentrated bolus for sacral pain, or sometimes you may have to give lignocaine, 2% lignocaine or chlorprocaine may affect if the bupivacaine is not functioning properly in the high lumbar space. When it comes to the second stage pain, if not functioning, you may have to use these techniques to have a sacral analgesia towards the end of the labor. Then a word about caudal epidural analgesia. It is now more common. It's mainly historical. But it is used by some experienced persons in the second stage. But the concerns regarding efficacy of the block is there, and it requires larger amount of local anesthetic, which causes a significant maternal hypotension. Chance of infection is there, but there is less chance of dural puncture. But it is not commonly practiced now, and it is almost abandoned as a technique of neuraxial analgesia for labor. Then for vacuum assisted delivery and forceps delivery, vacuum is less painful than forceps delivery. If a functioning epidural is there, maintain analgesia. If needed, epidural bolus is needed. So functioning labor analgesia can be used, and like a sacral analgesia, one can supplement the analgesia or anesthesia for vacuum delivery, as well as for forceps delivery. Forceps delivery is more painful than vacuum. And another thing is the incidence of vacuum and forceps is found to be more when epidurals or regional analgesia is given for obstetric analgesia. So one has to give the forceps delivery, and the suturing of the episiotomy also has to be provided adequate analgesia through the epidural boluses with the sensory drug, and sometimes you may have to use a higher concentration drug or lignocaine. And if needed, a bicarbonate may be added for the top up of these methods, these stages, for a quicker onset. And if no epidural catheter is there, a single shot spinal for instrumental delivery, sitting spinal may be needed. And if time permits, you can do some combined spinal epidural. And this can, if needed, surgical anesthesia can be delivered through the epidural catheter. And lastly, I talk about the last. There is a local anesthetic systemic toxicity. That is a very dangerous, and we should have all the precautions to treat. And it is always preferable or ideal to have a intralipid infusion available in every obstetric analgesia suite to manage any unexpected occurrence of a local anesthetic toxicity, either by an accidental intravascular injection or an unanticipated high dosage. A nurse or somebody giving a high concentration. So it is essential to have an intralipid infusion and all the methods to resuscitate an obstetric patient. One should be very well versed to resuscitation in obstetric patients, the cardiopulmonary resuscitation, the fetal resuscitation. One should have all the facilities and equipments. So I'm not going to management of local anesthetic toxicity. You have to manage the arrhythmias, you have to monitor the cardiopulmonary resuscitation, you have to institute, and all these things has to be managed. So to summarize, I'm almost taken more than 45 minutes now. So maternal request is sufficient for labor analgesia. Neuraxial techniques may be done at any stage of labor. And there are absolute contraindications are very rare for giving labor analgesia. The commonly used techniques are continuous epidural or combined spinal epidural. A combination of local anesthetic and opioid is preferred. Always see that there is only a sensory blockade is attained and motor blockade is not there for participation of the mother during pushing of the fetus. And test dose or the drug top-up should not be given during a contraction. And monitor closely for high block and local anesthetic toxicity. And always have facilities for maternal as well as fetal resuscitation before instituting any obstetric analgesia. So with this, I am coming to end of my session on the on the aspects of neuraxial blockade of anesthesia, obstetric analgesia. Thank you very much.
Thank you, sir, for the excellent presentation. I think he has covered almost all areas, especially for the practical aspects for the examination point of view. Now the session is open for questions. And I can see one question from how less minimal platelet count can be allowed in neuraxial anesthesia, sir? So
that is as per the standard guidelines. It applies to obstetric analgesia also.
Okay. So any questions or comments from the faculties?
So Dr. Naresh Paliwal is there. He is there with one question. Now, Dr.
Yes,
Naresh, you can unmute and ask directly.
Dr. Naresh Paliwal?
Hello.
Yes, sir, please.
Can you hear me?
Yeah.
Oh, can there be a walking spinal like walking epidural?
Walking spinal is not, I don't think it is possible, because spinal, it is more likely to produce a denser block. And personally, I would not prefer to give a spinal for epidural for analgesia, unless it is in a late stage of delivery or in a failed epidural or converted into a spinal. I don't think an anticipated or a planned walking spinal is advised for a.
Whenever you have used a continuous spinal or a single shot spinal as a choice, then is it possible to have a walking spinal? Because there are many drugs in a low concentration. If they are used, they will produce a segmental effect. Just 1.5 to 2 ml of the 0.0625%. Ropivacaine, which has a preferential sensory blocks, then it can produce sensory blocks only. and you can
Combined
very well
spinal
have a,
epidural, combined spinal epidural is described as a walking
yeah,
epidural.
that is described as a walking epidural.
Yeah.
But when you use a local anesthesia through intrathecal route, so
Yeah.
my question was, is it possible? Theoretically, it is possible. I have actually not getting the references, but after using so many of these things, not exactly used for labor analgesia, but walking spinal is feasible with very low doses and low concentrations of local anesthetics, along with the opioids, whatever you use, like fentanyl.
But our micro catheters are not freely available for us, and
The micro catheters are not available. We are actually convert our epidurals when you get an accidental dural puncture during epidurals. Most of the times you have to convert this in a continuous spinal anesthesia. And another question is, what drugs you prefer, isobaric or hyperbaric through CSA?
For us, the hyperbaric is the one we are having it right now. Isobaric is not freely available for us. Isobaric can be used.
Isobaric is freely available. Leo, anavine, and ropivacaine things available are isobaric only. Though on the verge of being slightly hypobaric, they are considered as isobaric drugs.
And once you want to have
not mentioned in your
and once if you want a sacral analgesia, you can use hyperbaric, and otherwise you can use isobaric also.
But that will give a complete anesthesia, sacral anesthesia. The patient will not be able to move. So you can increase the dose of isobaric drugs to have a sacral blockade, even through continuous spinal analgesia.
Yeah, regarding the walking spinal, and another thing is, once if you are using an epidural catheter, the relatively higher bore puncture, there is a chance of more of a post-dural puncture headache when you allow them to have a walking spinal.
No, when the catheter is in position, and it is recommended that you should keep the catheter in place for at least 24 hours to avoid PDPH.
Yeah.
That is one recommendation. And another recommendation is you should give some saline, some 10-20 cc through intrathecal route before taking out the catheter, if you are removing it before 24 hours to avoid the PDPH. But still there can be PDPH even if you don't allow the patient to move.
Yeah.
One advantage of combining spinal with epidural is that the patient will get immediate pain relief.
Immediate effect.
Yeah. So
what is the and what is the initial dose? Like you have not mentioned the initial dose of in continuous spinal anesthesia. What you just mentioned the concentration, but not the initial volume. What volume do you prefer?
Practically, I haven't used a continuous spinal or spinal for the obstetric analgesia, but you have to 0.625% of bupivacaine.
That's okay. That's actually isobaric. If you mix with normal saline, if you mix it with distilled water, then it will become hypobaric. So you can use it according to need. According to the position of the patient. But initial volume should not be more than 0.5 to 1 ml in continuous spinal. And you have to use a 1 ml syringe for especially, and you have to take into account the dead space of the catheter. Especially when you're using an epidural catheter, the dead space can be very high. Just around 0.5 to 1 ml can be the dead space of the epidural catheter. So you have to take into account that dead space, because when you give a next dose, the remaining amount in the dead space will be going to the patient. So either you have to flush the catheter with normal saline or give a last dose as a fentanyl.
Okay.
Any questions?
Okay, thank you for the input, sir.
Is there one doubt, that is there any role for epidural volume expansion for labor analgesia? Epidural volume expansion.
Volume extension technique.
Epidural volume expansion technique for labor analgesia.
Giving higher dose, higher volume.
Yes, higher volume with the normal saline, and at the same time.
Can I add to it?
and the
please.
spinal anesthesia and the spinal
please.
drug.
Yeah, please, sir.
Epidural volume extension technique is a known technique. When you give a very
Yes.
low dose intrathecally, you can extend the spread of the block by
Right,
giving
spread
normal
as well as
saline
the
through the epidural catheter.
The sensory
about 10
block
to
can
20
be
ml.
prolonged.
Yeah, can be not prolonged, but you can spread it to wider segments. Actually,
Yes.
when you give a very little dose, it is not only for labor analgesia, but even in other cases also, when you use combined spinal epidurals, by
Yes, we
compression
can
of
use
the
it
epidural
in-
space, it can spread the same dose to wider segments. So this can be used when you are using very low doses intrathecally. You can use normal saline through epidural to have a epidural volume extension technique.
For labor analgesia, usually we recommended it for hemodynamically unstable patients. But sir, are you giving this for labor analgesia also, epidural volume expansion methods?
For me,
The question is, sir, you have given, that's why
no,
epidural volume expansion
I
technique.
have not
No,
used it for
not
labor
used.
analgesia.
Okay.
I just told about the epidural volume extension technique,
Volume expansion. Okay.
not routinely doing this labor analgesia.
So higher
But this
volume
can
will
be
definitely,
used. Theoretically, it is possible.
yeah, higher volume will definitely give a better spread.
A
Yes,
higher
but
volume of
spread
normal saline through epidural. It is just to
epidurally
compress
and
the
the
thicker
intrathecal
space.
drug for the spinal drug for intrathecal.
But it will reduce the concentration of the drug also. That is
Yes,
also there.
it will reduce the concentration, but the sensory blockade may be higher level as the volume increases.
No.
But
You are just
hemodynamically
getting
unstable
confused.
patients usually we can use.
It's just there is little confusion. You have to give us little dose, just say 1 ml through intrathecal space in spinal, and
Yes.
immediately it is a time-bound procedure, and especially possible with isobaric drugs only, because hyperbaric drugs it will spread with gravity only. With isobaric drugs, you can use a volume extension technique. You can give normal saline through epidural space to increase the dose of intrathecal drug which you have already given to wider segments. So there will be no dilution. Actually, the dose will be same, but it will be spread to wider segments
By the
by
segments.
compression of the thecal space.
Yes, that's the method that we are using.
Yeah. Thank you.
Sir, you
There's
have mentioned about the opioid use, fentanyl and subfentanyl use in subarachnoid blocks. So, what is the present legal status of use of subfentanyl in India and fentanyl in subarachnoid blocks?
Specific legal aspects I am not. It is like any other intrathecal opioid use. You have to consider the problems of intrathecal opioids like pruritus and other problems.
Sir, I'm not asking about the clinical side effects. I'm asking about the legal status of it, because if it's legally permitted, then we can use it in our studies. Otherwise, it will not be it will be difficult to use in our studies. No, that's why I asked.
It is well described, and I don't think it is legally bad. It will not cause any problem. But provided using the correct dose, correct monitoring.
Dr. Binil, why
Is there
you
any
are
problem?
worried about the legal problem? Because it's not preservative free?
Yeah, because as per Indian Pharmacopoeia, what is the present status of use of fentanyl or fentanyl in subarachnoid blocks, not in epidural, subarachnoid?
That we are using.
Legal aspect, I'm not that much.
Yes,
Shamshad?
yes, I don't think there is any legal problem because we have to monitor the patient and we are giving it intrathecally. That's all. We are using it.
We have to take all the
I think
precautions.
we can. I think we can.
Dr. Binil, it is well described in literature, the intrathecal use of opioids.
It's well described.
Yeah, that is there. That is there, sir. Yeah.
And then what's the problem?
Then what is the problem?
No, actually, use of opioid in even regional techniques. I don't know whether it's as per Indian pharmacopoeia, whether it's permitted for all the drugs. Some drugs it's there, the permission is there, and some drugs I don't know what's the status. That's why I asked. Regarding sufentanil, I got some doubts. That's why I asked.
No, I don't have any references that there is any contraindications or anything, any legal problems.
As far
Do
as
you-
remifentanil, it is absolute contraindication because of neurotoxicity. I don't think, I don't know about zufentanil, but fentanyl, there is a lot of literature evidence.
Yes, sir.
Remifentanil, definitely, no, absolute contraindication because it's contraindicated for Neuraxial technique.
Any other
Dr.
questions, sir?
Binal, is sufentanil available in India?
It was available, madam. It was freely available in India. At present status, I don't know actually. It was available earlier.
But I don't think nowadays we are not allowed. I haven't used it at all, but it's not available to us. I think so. As cardiac anesthetist, you may be getting it.
No,
Is it?
madam. Earlier it was available. Now I don't know. Now we are not getting.
Yes, okay.
With the advent of remifentanil, the use of alfentanil and zufentanil has come down.
Sir, if there is no more questions, shall we move on to next topic, sir?
Yes, please. And thank you, Mubarak, sir, for the wonderful presentation.
Yes, Mubarak, thank you.
And those postgraduates who has not joined in PG update group, ISA Kerala PG update group, please give a WhatsApp message to any of the coordinators, either to Dr. Binil, Dr. Bijish, myself, Dr. Shamshad Begum, or Dr. Polo Rafid. We'll add you in the group. And we request the postgraduates to present the topic like for the PG corner also. Over to Dr. Binil.
Thank you, Mubarak, sir, for the excellent presentation on Neuraxial Blockade, especially in Obstetric Analgesia. As usual, it was a wonderful presentation. And now we will move on to our next session, that is our PG corner. Two young doctors from Government Medical College Trivandrum will be presenting today's PG corner session. They will be presenting Ketamine and Epidural Needle. Dr. Rakhi Mohan and Dr. Rahul Dev. And to coordinate the session, I welcome Dr. Lynette Morris, Professor and HOD of Government Medical College Trivandrum. Madam does not require any introduction because we all know her very well. So I welcome Dr. Lynette Morris to start the session. Or to Madam, sir.
Okay, good evening to all. Am I audible?
Yeah, Madam, you are audible.
Okay, so thank you, Dr. Binil. And now we move on to the PG session. We have two residents, Dr. Rakhi and Dr. Rahul. So first, Dr. Rakhi will be presenting the drug Ketamine. After that, Dr. Rahul will be presenting his epidural needle. So over to Rakhi.
Madam, I'm audible?
Yes.
Hello?
Yes, Rakhi. Yes,
Okay,
you are
madam.
audible.
Madam, screen കാണാവോ madam?
Kanam.
Okay. Good evening, one and all. Today's topic is ketamine. Now, starting with the history of ketamine, it's a phencyclidine derivative which was first synthesized in 1962 by Stevens. It was first used in humans in 1965 by Corson and Domino. So, 1962 by Stevens, and then in 1965 by Corson and Domino. Now, let's start with the properties of ketamine.
Sorry to interrupt you.
Yes,
I'm
okay.
not able to see this.
Not able to see the slides.
Others, I don't know.
Slides കാണാൻ
And the slides are not visible.
Yeah, you
Lights
can start
കാണുന്നില്ല
the
Rakhi.
slide share.
slide share ആവുന്നില്ല. ഒരു മിനിറ്റ് മാഡം.
Yeah, you take your time. No issues.
ഒരു മിനിറ്റ് രാഹുലിന്റെ ഇതിൽ നിന്ന് കയറുവാണ്. Sorry for the delay.
Okay, fine.
Sharing option ഇപ്പം വരുന്നില്ല മാഡം. Only host can share അങ്ങനെയാ വരുന്നത്.
Wait.
Lucky, you can share from your phone and Rahul.
Your main co-host, you can share. Is it Rahul's phone you are using?
Rahul's phone, yes sir. I'm using
Yeah, just try now from your Rahul's phone. Rahul Dev.
Rahul will share ചെയ്യുക.
Yeah, now it's sharing.
വരുന്നുണ്ടോ?
Yes.
Yeah, now it's sharing. Just open your PPT. Yeah.
Yes.
Okay.
Yeah, please
Start
proceed.
it. Okay. Now, starting with ketamine. Now, starting with the history of ketamine. Ketamine is a phencyclidine derivative. It was synthesized in 1962 by Stevens. It is first used in humans in 1965 by Corson and Domino. Now, let's move on with the properties of ketamine. Now, ketamine has a molecular weight of 238 kilodalton. It is partially water soluble and it forms a white crystalline salt. It has a pK of 7.5. The lipid solubility of ketamine is 5 to 10 times that of TPS, and it is 12% protein bound. The bioavailability is 93% after parenteral route and 20% after route. Now, why 20%? Because it's first class metabolism. Now, even after nasal route, the bioavailability is 40 to 50%. Now, the structure of ketamine. Now, other properties of ketamine. Ketamine is a racemic mixture of R minus and S plus ketamine. Why a racemic mixture? It is due to the presence of an asymmetric carbon atom, which results in these two isomers. R minus, that is the right-sided isomer, and S plus ketamine. S plus ketamine is also known as ketanist. Now, S plus isomer, it is 3 to 4 times more potent analgesic, and it has faster clearance as well as faster recovery, and the psychomimetic effects are few. Even though the psychomimetic effects are fewer, but still it can affect the cognitive impairment, it can cause cognitive impairment, memory impairment, and it can also decrease the reaction time. Now, both the isomers, they inhibit the uptake of catecholamines back into the postganglionic sympathetic nerve endings. This is similar to the drug cocaine. So it produces cocaine-like effect, that is, inhibit the uptake of catecholamines back into the postganglionic nerve endings. The preservative used in ketamine is benzethonium fluoride. Moving on to the pharmacokinetics of ketamine. It is metabolized by hepatic microsomal enzyme. First, N-demethylation occurs. Metabolite I, which is also known as norketamine. This norketamine has 20 to 30% properties of analgesic property of that of ketamine. Now, this norketamine is further hydroxylated to form hydroxynorketamine. Then it is conjugated to form water-soluble glucuronide derivatives. Since it's water-soluble, excreted in urine. So the active metabolite which is formed is norketamine, which is also known as metabolite I. Now, in this figure, we can see how ketamine is metabolized. Then it's metabolized to norketamine, which is also known as metabolite I. It is hydroxylated to form hydroxynorketamine. Then it is excreted as water-soluble products in the urine. Now, as mentioned earlier, the activity of norketamine is 20 to 30% that of the parent compound. Now, the advantage of ketamine is that it has rapid onset of action. The peak plasma concentration occurs within 1 minute if you're giving it IV, and 5 minutes if you're giving it IM. Initially, ketamine is distributed to highly perfused tissues, that is to your brain, Why? It is having high lipid solubility. So rapid transfer across the blood-brain barrier occurs. Also, ketamine is a potent cerebral vasodilator. So there is increased delivery of drug to the brain. Now, ketamine is then distributed from brain and other highly perfused tissues to less perfused tissues. So this produces the late psychodynamic effects which occur after emergence. Now, as mentioned earlier, it has high lipid solubility. It is 5 to 10 times that of TPS. So it has a large volume of distribution, which is approximately 3 liters per kg. It has a high hepatic clearance, equal to that of the hepatic blood flow, 1 to 1.4 liters per minute. The elimination half time is 2 to 3 hours. Now, moving on to the pharmacodynamics, let's see what ketamine does in our body. It produces dose-related unconsciousness as well as analgesia. It acts on multiple receptors, starting from the NMDA receptors. So it binds non-competitively to the phencyclidine recognition site on the NMDA receptor, that is the N-methyl D-aspartate receptor. Other sites of action of ketamine are opioid receptors, monoamologic receptors, muscarinic receptors, voltage-sensitive sodium, and L-type calcium channels. It also acts on the neural nicotinic acetylcholine receptors. But it has a weak action at the GABA receptors, unlike benzodiazepine propofol. Ketamine also suppresses the neutrophil production of the inflammatory mediators. This improves the blood flow. Also, there is inhibition of the cytokines in the blood by ketamine. This also contributes to its analgesic effect. Now we'll start with the NMDA receptor. The NMDA receptor is a member of the glutamate receptor family. These are ligand-gated ion channels. Now, ketamine, it inhibits activation of NMDA receptors by the glutamate. Also, decreases the presynaptic release of glutamate. Now, the opioid receptors. We know that ketamine has analgesic action due to multiple reasons. And one of the reasons is this. Ketamine interacts with the mu, delta, kappa opioid receptors. In fact, some studies have shown that it has antagonistic effect at the mu receptor and agonistic effect at the kappa receptor. Moving on to the monoamologic receptors. Now, ketamine activates the descending inhibitory monoamologenic pain pathways. So this is also responsible for its anti-nociceptive action. Now, we know that ketamine produces multiple anticholinergic symptoms like emergence delirium, bronchodilation, sympathomimetic action. All these are due to its antagonistic effect. It is antagonistic effect at the muscarinic receptor. Now, it also has actions at the sodium channels and the acetylcholine receptors. Now, we know it has mild local anesthetic-like properties. This is because ketamine interacts with the voltage-gated sodium channels. It shares its binding sites with the local anesthetic. It also interacts with the nicotinic acetylcholine receptors. This is also important for its analgesic property. Now let's see its action on the central nervous system. This produces dose-related unconsciousness and analgesia. Now, at the spinal cord level, it has anti-nociceptive action at the NMDA receptor. It also inhibits the acetylcholine release. Now, the anesthetic state is known as dissociative anesthesia. That is, the patient is in a cataleptic state. That is, patient will be having profound analgesia, but eyes will be kept open and the reflexes are maintained. That is, the corneal, cough, swallow reflexes, all are maintained. But it doesn't mean that always these reflexes are protective. Now, amnesia is produced by ketamine, but it is not as prominent as those produced by benzodiazepine. Now, ketamine has low molecular weight and its pK is near to that of the physiological pH, and it has high lipid solubility. All these factors results in rapid crossing across the blood-brain barrier. So, as mentioned earlier, onset of action is just within 30 to 60 seconds after IV injection. Now, after administration of ketamine, the pupils dilate. There is nystagmus, there is lacrimation and salivation occurs. There is increase in the skeletal muscle tone. Also, there is purposeless movements of the arms, legs, trunk, and head. There's increase in cerebral blood flow as well as increase in the CMRO2. But the increase in cerebral blood flow is more than that of the increase in CMRO2. Now, intracranial pressure. Now, as mentioned earlier, ketamine is a potent cerebral vasodilator. It increases the cerebral blood flow by 50%, that is in the presence of normocapnia. So, if suppose a patient is having some intracranial pathology, this can produce increase in the ICP. But in patients with mildly increased ICP, ketamine can be administered with mild hyperventilation. Prior administration of thiopental, diazepam, or midazolam can be used to blunt this ketamine-induced increase in the cerebral blood flow. But still, it should be used in caution in patients with raised ICP. Now, increase in cerebral blood flow is higher than the increase in CMRO2. Here, the cerebrovascular responsiveness is, to carbon dioxide is preserved with ketamine. So, reducing the PuO2 actually attenuates the rise in ICP, which is produced after administering ketamine. Now, ketamine is said to have neuroprotective effects. Now, the activation of NMDA receptor is thought to have some effects on producing cerebral ischemic damage. Now, we know that ketamine is an NMDA antagonist. So, it is possibly considered to be neuroprotective. And the effect is mediated through its anti-apoptotic mechanisms. Now, let's see its effect on the electroencephalogram. There is abolition of the alpha rhythm and there is dominance of the theta activity. When you give it high doses, burst suppression pattern is seen. Then excitatory activity occurs only in the thalamic and the limbic system, but the cortical system is spared. The cortical areas is spared. Now, this does not alter the seizure threshold in epileptic patients. So that's another point to be remembered. Now, on the somatosensory evoked potential, it increases the cortical amplitude of the somatosensory potential. But this effect can be attenuated by nitrous oxide. The auditory and visual evoked responses are decreased by ketamine. Now, we know that the NMDA receptor is thought to produce hyperalgesia and anti-nociceptive tolerance, which is produced by the opioids. So, if you give prophylactic ketamine, this prevents the central sensitization and the long-lasting enhancement in the pain sensitivity, which is produced by opioids. This drug selectively depresses the neuronal function in cortex and the thalamus, but it stimulates the limbic system, including hypothalamus. So this produces a functional disorganization. We know that it has action on the opioid receptors. It occupies the opioid receptors in the brain and the spinal cord. This is also responsible for its analgesic action. Then spinal cord analgesic effect is produced by the inhibition of the dorsal horn bidynamic range neuronal activity. Now, psychedelic reactions. Ketamine is well known for its psychedelic reactions. Ketamine produces undesirable psychological reaction, and this occurs during awakening. This is known as emergence reaction. That is, patient will complain of vivid dreaming, extracorporeal experiences. There will be illusions. Then it will be associated with excitement, confusion, euphoria, fear. This occurs in first hour of emergence, but it abates within 1 to several hours. Now, this is why there is psychic emergence reaction. This is due to ketamine-induced depression of the auditory and visual relay nucleus, that is the inferior colliculus and the medial geniculate nucleus. Now, incidence of this emergence reaction can range from 3% to 30%. Now, what are the factors causing increased incidence of emergence reaction? It is age. As age increases, or if the dose is increasing, that is more than 2 mg per kg, female population, patients already with psychological susceptibility, and concurrent use of other drugs. Now, benzodiazepines are the most effective group to prevent the psychedelic reactions, which is produced by ketamine. Now, let's move on to the effects of ketamine on the respiratory system. Now, minimal effects on the respiratory drive is being seen, as mentioned earlier. There is unaltered response to the carbon dioxide drive. Then there can be a transient decrease in minute ventilation when you're giving a bolus dose of 2 mg per kg. But if you give large doses, rarely apnea can be there. Then ketamine depresses the ventilatory control in children, especially if it is given at high bolus doses and rapidly. So that point should be kept in mind. Then it's a bronchial muscle relaxant. So when it's given in patients with reactive airway disease or bronchospasm, the pulmonary compliance can be improved. So it can be used in patients with a reactive airway disease and pulmonary disease. Now, why? It antagonizes the spasmogenic effects, which is produced by carbachol and histamine. Also, it can be used in the treatment of status asthmaticus, which is unresponsive to the conventional therapy. But one thing should be kept in mind, always an anticholinergic, glycopyrrolate or atropine, preferably glycopyrrolate, is given for the increased salivation, which is produced by ketamine. The upper airway muscle tone is maintained with ketamine. The reflexes remain intact, even though not always protective. Now, moving on to the effects produced on the cardiovascular system. Ketamine produces cardiovascular effects that resemble the normal sympathetic nervous system stimulation. So the point to be kept in mind is an intact sympathetic nervous system is necessary for the action of ketamine. It increases the arterial blood pressure, it increases the heart rate, increases cardiac output. All this occurs in a biphasic manner. The thing is, it has direct cardiodepressant effect, also negative inotropic effect. This can occur to the indirect stimulatory effect, which occurs to activation of sympathetic system. Why there is activation of the sympathetic system? How does it happen? There is systemic release of catecholamines. There is inhibition of the vagal nerve, inhibition of the norepinephrine reuptake, which occurs at the peripheral nerves and the myocardium. So there's tachycardia, increase in systemic pressure, pulmonary pressure, increase in cardiac output, and myocardial oxygen consumption. Now, all these effects can be minimized or prevented, in fact, by prior administration of benzodiazepine or concomitant administration of inhaled anesthetics, which includes nitrous oxide. Now, but the point to be kept in mind is that the critically ill patients, in some critically ill patients, suppose we are giving ketamine, there can be sudden decrease in blood pressure and cardiac output. Why? The catecholamine stores will be depleted in such patients. So, unmasking of ketamine's direct myocardial depressant effects and negative inotropic effects will come there. Now, ketamine also increases the arterial lactate concentration. How does it happen? This is due to inadequate tissue perfusion. So, ketamine causes vasoconstriction. It maintains the systemic blood pressure, but the tissue perfusion is not maintained. So, there is increase in lactate concentration. So there's increase in heart rate, there is increase in cardiac output, there is increase in myocardial work, oxygen consumption. So in a healthy heart, the cardiac output increases and coronary vascular resistance decreases. And patients with congenital heart disease, there is no significant change in the shunt fraction or oxygenation. There's mitral valve and some congenital lesions. Now, the increase in pulmonary artery resistance is much more than that of the systemic vascular resistance. So, we should know that there is no change in the shunt fraction or systemic oxygenation in congenital heart disease patients after administering ketamine. Now, let's see what happens to the cardiac rhythm. Ketamine actually enhances the dysarrhythmogenicity of epinephrine. Now, the hepatic or renal function, no significant alteration occurs. Allergic reactions are rare, even though if it occurs, there is no much release of histamine. Now, what happens to the platelet aggregation? This point should be kept in mind. Ketamine inhibits the aggregation of platelet. This is by decreasing the formation of inositol 1,4-triphosphate and also the inhibition of systolic free calcium concentration. So, it inhibits platelet aggregation. Now, let's move on to the clinical uses of ketamine. It can be used for the induction and maintenance of anesthesia. That is, suppose a patient is coming in severe hypovolemia, shock, hypotensive patient, cardiovascular depression which occurs in sepsis. In such patients, ketamine is always considered. Now, also in patients with reactive airway disease. Why? Because it produces bronchodilation. Now, trauma patients is coming to OT. An extensive blood loss is there. We can consider rapid sequence induction with ketamine. Also, it can be used in septic shock. But we should know that if the catecholamine stores are depleted, the intrinsic myocardial depressant effect of ketamine will manifest. Other uses include cardiac tamponade, restrictive pericarditis. These are the other uses. Ketamine preserves the heart rate and the right atrial pressure through its sympathetic stimulating effects. It's used in patients with right to left shunt, it is especially tetralogy of Fallot, along with dexmedetomidine. It can be used in patients susceptible to malignant hyperthermia also. Now, ketamine along with propofol or midazolam can be given as continuous infusions, especially in patients with valvular and ischemic heart disease, not as a sole agent. Because if you're giving combining propofol and midazolam along with ketamine, the unwanted tachycardia, hypertension, all these psychological derangements which is produced by ketamine can be avoided. In fact, ketamine plus propofol can be used for total IV anesthesia in non-cardiac surgical procedures. Why? Because it has stable hemodynamics and minimal ventilatory depression. Ketamine does not produce any pain or venous irritation on injection, and it has rapid onset of action, that is within 30 to 60 seconds after IV administration. In fact, it is an IM drug, induction drug in children, especially mentally challenged children. Now, the analgesic effects is due to its action in the sympathetic nerve system as well as the limbic system. Now, ketamine also constitutes of the multimodal analgesia. It decreases the post-op analgesic consumption by 33%. You can decrease opioid use. So, the opioid-induced side effects like post-op nausea, vomiting can be decreased. It can be used in chronic pain states, cancer pain, chronic peripheral central neuropathic pain, phantom pain, ischemic limb pain, fibromyalgia, complex regional pain, visceral pain, migraine, in such situations. So literally it can be used for pain management. The fact is that it is more effective for somatic pain than visceral pain. Then it can also be given epidurally or caudally at a dose of 0.5 to 1 mg per kg. But here preservative-free ketamine should be used. Then IV ketamine can also be used for positioning patients with extremity fractures. Then analgesia is more greater for somatic pain than visceral pain. Then it can be used for post-op sedation and analgesia in pediatric cardiac surgery, that is at a dose of 1 to 2 mg per kg per hour. Also, it can be used for burn stressing changes, debridement, skin grafting procedures. Also, it can be used. Then sedation, it can be used with sedation, but it should be combined with either benzodiazepines or barbiturates because it produces psychedelic reaction. And another thing is an anti-saligogue should be used because increased chance of salivation is there. So it's preferred as glycopyrrole. Then it can be used as supplement or it can be used as an adjuvant to regional anesthesia. Now, sedation, it can also be used for sedation of patients in critical care unit because it has analgesic property. Next is it has stable hemodynamics. Also for sedation of pediatric patients outside.
Raki, sorry to interfere. Your slides are not moving. Now it's on.
So if the movie
now I can see sedation.
So repeat it, no, sir.
Venda. Please proceed.
Okay. So it can also be used for reversal of opioid tolerance. So sub-anesthetic dose of ketamine, that is at a dose of 0.3 mg per kg per hour, it improves analgesia and decreased chance of developing opioid tolerance. Then improvement in psychiatric disorders. Now, recent studies have shown that the NMDA receptor is involved as in the pathophysiology of mental depression. So ketamine can be used in patients, especially with mental depression. Also, it can be used to suppress the obsession and compulsion in patients with obsessive compulsive disorder. It can also be used in restless leg syndrome because, as mentioned earlier, it inhibits the neuroinflammation in the spinal cord, also the higher symptoms. Now, let's see the uses and the dose of ketamine along with the rules. Now, for induction of general anesthesia, a dose of 0.5 to 2 mg per kg IV is preferred and 4 to 6 mg per kg IM is preferred. For maintenance of general anesthesia, a dose of 0.5 to 1 mg per kg if it is used with nitrous oxide, that is 15 to 45 mics per kg per minute with nitrous oxide and oxygen. If nitrous oxide is not used, dose of 30 to 90 mics per kg per minute is used. For sedation and analgesia, a dose of 0.2 to 0.8 mg per kg, which can be given over 2 to 3 minutes. Now, if it's given IM, 2 to 4 mg per kg. Now, for preventive analgesia, 0.15 to 0.25 mg per kg can be given. Routes, it can be given either by oral route, IV route, IM route, intrathecal, epidural, rectal, and nasal. Rectal doses 10 to 30 mg per kg. Nasal, it is 4 to 6 mg per kg. Also, gargle is available, 50 mg per ml. Caudal, epidural, or intrathecal, it can be given. Preservative free should be used, that is 0.5 mg per kg. Now, let's see the side effects and contraindication of ketamine. Now, as mentioned earlier, we know that we should be careful if you're giving ketamine to a patient with raised intracranial pressure and if the patient is spontaneously breathing. Next is open eye injury. There is increase in intraocular pressure after giving ketamine. Also, ischemic heart disease is a sole agent because ketamine can be combined with either propofol or benzodiazepines, but not as a sole agent because it increases heart rate, it increases the myocardial oxygen consumption. Also in vascular aneurysm patients, because there is rapid change in the arterial pressure. Also psychiatric illness like schizophrenia. Such patients you should be careful. The preservative use, chlorobutanol, can be neurotoxic. Therefore, it is contraindicated when used in subarachnoid or epidural administration. Then, even though liver and renal toxicity is rare, if the person is using it continuously, there is recreational abuse is there. Can occur. Also, emergence delirium, which is the psychedelic effect, which occurs mainly due to the depression of the inferior colliculus and the medial geniculate nucleus. That is, the visual and auditory stimulus is not seen properly. Thank you.
Thank you, Raki. Thank you for the presentation. And now the subject is open for discussion. If you have any questions, you can ask queries.
Dr. Raki, hello, can you hear
Yes,
me?
sir. Hello, sir.
Yeah,
Yes,
you have mentioned about ketamine available as gargles. Yeah, and the dose also you have described 50 milligram per ml, isn't it?
Yes, sir.
You check your slides. Yeah. So where do you think
Yes, sir,
its application in anesthesia practice?
So awake intubation, it can be used, sir.
Not it's used as a gargle in a postoperative sore throat.
So,
Okay, there are studies, so you can check in the so you can Google and find the postoperative sore throat and application of ketamine gargles. Okay, and another application is widespread application is in neuropathic pain. When the pain is refractory to usual step ladder of neuropathic pain, like antidepressants or like tricyclic antidepressants, GABA inhibitors, or pregabalin. So what do you think is the mechanism? The mechanism is the hypersensitivity to your NMDA receptors, which is responsible for the genesis of neuropathic pain, and you have described that it is a potent NMDA receptor antagonist.
yes, sir.
Okay, you have presented well. Just a couple of comments from what you have presented only. And whenever you mentioned ketamine, you have to mention its potential use in neuropathic pain. And it's also used in phantom limb pain also.
Yes.
And it's good that you are mentioned about its use in as an antidepressants and intractable fits. In fact, we get the calls for the to initiate the ketamine infusion in case of intractable fits. Okay. And you have sent about spasmodic effect of carbacholic and histamine.
Histamine.
Yeah. It's used nowadays. It's explored as a possible agent for refractory renal colic. Okay. Anyway, you are presented well. Good.
Thank you, sir.
Right.
So now we move on to the next presenter. He is Dr. Rahul Dev. He will be presenting on the topic of epidural needle. Over to Rahul.
Thank you, ma'am. Good evening, everyone. Today's topic of presentation is epidural needle. Before going to epidural needle, I'm going to talk about epidural anesthesia. First of all, history. The first lumbar epidural anesthesia in human was described by Pages in 1921. The laws of resistance technique described by Dogliotti in the year of 1930. The first description of caudal anesthesia reported by Kathleen, and Leonard Corning attempted epidural anesthesia with cocaine on humans after assessing its action on dog first. Continuous caudal for obstetrics done in 1941 by Hickson, and lumbar epidural catheterization for surgery was done by Curbelo in 1947. And the use of epidural morphine analgesia was first reported by Behar in 1979. Next is the advantages of epidural. The epidural technique allows for the placement of continuous catheter, which is especially useful for cases of unpredictable duration, prolonged postoperative analgesia, chronic pain control, and obstetric analgesia and anesthesia. Definition of an epidural space. The epidural space is considered as everything outside the dural sac but within the vertebral canal constitute the epidural space, which extends from the foramen magnum to the sacral hiatus and surrounds the dura mater anteriorly, laterally, and posteriorly. The boundaries of epidural space are anteriorly, posterior longitudinal ligament, vertebral bodies, and disc. Laterally, pedicle and intervertebral foramina. Posterior, ligamentum flavum and the lamina. The picture showing the epidural space and its boundaries. Next, the content of epidural space, which constitute epidural fat, vessels including the Batson plexus, nerves, and the lymphatics. The epidural fat permits the gliding movements of the neural tissue and also provides a padding effect. Epidural space from skin approximately 4 to 6.9 centimeters in thoracocervical and lower thoracic region, and 3 to 4.59 centimeters in thoracolumbar and mid-lumbar region. The lumbar vertebral canal nearly filled with the dural sac. So we'll go on to the epidural technique proper. For the preparation, we need a proper consent monitoring to set up the proper monitoring and resuscitation equipment and put a large IV cannula. Choosing the patient and the drug appropriately depending on the comorbidities and the nature of surgery. The sterility is more important. Catheter is often left in situ. Thorax and alcohol together is considered the most effective technique method. So before putting an epidural catheter, we should know the extent of surgical field and the where we have to go into put the epidural catheter. We used to put the thoracic surgeries at the we used to put epidural catheter at the level of T4 to T8, and upper abdominal surgeries around T6 to T8, and mid abdominal surgeries T7 to T10, and lower abdominal surgeries T8 to T11, and lower extremity surgeries we will put epidural catheter in between L1 and L4. Next, we'll go and discuss on the subject proper epidural needles. It's a picture of Dewey needle. This needle is the most commonly used needle in our setting. And Dewey needle is a 10 centimeter long needle with a shaft measuring 8 centimeter, which has a 1 centimeter marking and along with a stellate introducer, which will avoid the blockage of needle during puncture of skin. And the tip of the needle is having an angulated 20 degree to the shaft is known as the Huber point. And most of the anesthetists prefer a winged needle, and most commonly used are 16 gauge and 18 gauge Dewey needles. The markings in the Dewey needles help to assess the depth of epidural space and the shape of the bevel, which helps to avoid the dural puncture, accidental dural puncture, and also helps to the threading of the catheter. And the wing needle, they have a better control and handling. In pediatrics, we use a 19 gauge Dewey needle with a 5 centimeter long with a 0.5 centimeter markings. The newer technique is the combined epidural needle, which has a 26 gauge spiral needle with 12 centimeter length and a 60 gauge Dewey needle. We here use a needle to needle technique to give the combined spinal epidural. The problem here is we have to push more pressure for giving spinal drugs through these needles. The problems in practice and the safety feature. The most important is we have to withdraw the catheter and needle simultaneously, and otherwise the catheter will get sheared at the tip of the needle, and there's always have a high chance of accidental dural puncture. Next, some needle with historical importance, the Scott needle, which has a shaft protruding from the hub, permits easier threading and advancement of epidural catheters, particularly with 18-gauge catheters, which sometimes kink and curl within the standard hub. Then we have 18-gauge Crawford thin wall needle used for paramedian and paraspinous approach. This the specific tip of the needle will help to penetrate the tissue and become plugged in the tissue fragments. The other less commonly used needles are large check and Crowley needles and a fine 22-gauge Wetton needle. Wing needles were ideal for hanging drop technique, uterus technique, since the grip of the needle should be well away from the fluid drop on the hub of the needle. Then the Husted needle, it's a modified 2E needle. The heel to bevel distance is less than 27 millimeter and bevel angle is 12 to 15 degree. It has a rounded bevel which will avoid the catheter shearing at the tip of the needle. Then the epidural catheter. Epidural catheter is a 90 centimeter transparent, malleable, biologically inert catheter which is made up of nylon and Teflon. The distal, which has a distal side post and a round tip. The distal end marked 5 centimeter intervals. Additional 1 centimeter markings between 5 to 15 centimeters. It's a picture showing the epidural catheter, 2E needle, and the other sittings. Then there's a Porter's epidural catheter and the filter. You can see the markings over the epidural catheter. Then the epidural catheter has a proximal connection to lower lock and the filter. And now it's it's available in markets, coil reinforced epidural catheter which avoid kinking, and radio opaque epidural catheter which can be used in chronic pain. The problems in practice and safety features of epidural catheter. The catheter should be tested prior insertion, and there's always have chance for catheter migration. So whenever we give drug to the catheter, always confirm the position of the catheter by giving the test dose. And it's already told that with the catheter along with the needle. And once the catheter is removed, check for any breakage at the side port, since the side port is the weakest part of a catheter. And advancing the catheter too much can cause knotting. It's a picture showing the knotting in the tip of the catheter, which is just advanced on the epidural space. Then the filter. Filter measures 0.2 to 22 micrometer mesh, and which acts as a bacterial, viral, and foreign body filter. Then along with we get the loss of resistant device, low resistant puncture. We can use air or saline to assess the low resistance in the epidural space, which comes as a plastic or glass. And the side turn and of the needle entry, the lumbar be exactly the center and directed perpendicular. T7 and T12, upper border of the lower spine advanced on 2 centimeter and angulate to 70 degree. T2 to T6 angulate to 40 degree, and cervical C7 to T1 due to perpendicular approach. The picture showing different approaches of epidural needle in the different positions. And the approaches, we have midline, paramedian, modified paramedian or Taylor's approach, and a caudal approach. A midline approach is the most common lumbar and low thoracic approach. The angle of approach is only be slightly cephalad in lumbar and low thoracic region, and a mid thoracic region more cephalad. Significant downward angulation of the spinous process. Paramedian approach, useful in mid to high thoracic region, angulation of spine and the narrow spaces. The needle should be inserted onto 2 centimeter lateral to the inferior tip of the spinous process, corresponding to the vertebra above the desired interspace. The needle inserted horizontally until the lamina is reached, and then redirected medially and cephalad to enter the epidural space. Then we have the Taylor's approach, modified paramedian approach. Modified paramedian approach via the L5S1 interspace, useful in trauma when the patient can tolerate the sitting position. Needles inserted 1 centimeter medial and 1 centimeter inferior to the posterior superior iliac spine, and anchored medially and cephalad at a 45 to 55 degree angle. Then the methods to identify the epidural space. The most historical and specific one is the loss of resistance technique of Dogliotti. It's very easy to learn, cost effective and not cumbersome, high sensitivity and specificity, fluid and air can be used. When we use the fluid, the disadvantage air is the disadvantages are the headache, pneumocephalus, cervical emphysema, patchy block and air embolism. When we use the saline, it can dilute the effect of local anesthetics, or if accidental dural puncture happens, we can confuse it for the CSF. Next is the hanging drop text or Gutierrez test. Subatmospheric pressure in the epidural space can suck in the saline dropped in the hub of the needle after loss of resistance. Quality of anesthesia not compromised, and more negative pressure in the thoracic epidural is considered unreliability. Vertical tube of Dawkins. The force of gravity used as a positive pressure, and vertical nylon tube, which is not more than 10 centimeter, filled with saline and air bubble. Needle enters the space and bubbles moves downward. Then we have Odom's indicator, a small capillary tube with saline containing 1 to 2 air bubbles attached to the needle hub. Bubble advances as needle enters the space. Then we have balloon technique of Macintosh. Balloon with 2 to 3 ml of air attached to the epidural needle and collapses when the needle enters the space. Then we have an epidrum, a small drum with diaphragm which collapses when the space is entered. Picture showing the application of epidrum. Then we have Eccles spring-loaded syringe. Spring unloads when the needle reaches the space. Then we have the Brook device, saline-filled capillary tube with a bubble. This end is heated to generate positive pressure. Bubble advance when the needle is in the space. So the more advanced one is the USG guided, which is a newer technique which helps to identify the better space identification, and it's also useful in obese patients. The other techniques are fluoroscopy, pro-impedance, optical reflectance spectrometry, Sweet technique, which helps to identify the epidural space by giving the current of 1 to 10 milliampere, and we'll see the stimulation of muscles in particular segment, and we can stimulate the muscle within less than 1 milliampere. We can suspect the needle in this place. Then we have the manometer technique of Selenka, a U-shaped manometer containing bubble in sterile water, tap in distal end into which the distended balloon is connected. Interspinous ligament device attached and tap open. Space reached the meniscus is reassessed. Height detection rate is shown by this method. Then we have the loss. This is the mainly we use the loss of resistance technique and hanging drop techniques. These are the pictures and the detailed information about the loss of resistance technique. In loss of that technique, air or saline is most commonly used, and most common the intermittent or the constant gentle pressure applied for the bulb of the syringe is the dominant thumb, while the needle is advanced with the non-dominant hand. A combination of air and saline may be used. When the epidural space is subsequently entered, the pressure applied to the syringe puncture allows the solution to flow without resistance. The air is less reliable in identifying the epidural space, higher chance of incomplete block, and cause both pneumocephalus and venous air embolism in rare cases. So when loss of resistance obtained, don't push extra air. In hanging drop technique, needle is placed into the ligamentum flavum. A drop of solution such as a saline is placed within the hub of the needle. Needle is advanced into the epidural space, and solution should be sucked in because of atmospheric pressure in the epidural space. The atmospheric pressure expansion of the epidural space as the needle pushes the dura away from the ligamentum flavum. After the epidural needle space is identified, the depth of the needle at the skin is noted. Syringe removed and catheter is generally threaded to approximately 15 to 18 centimeter mark. Needle withdrawn and the catheter is withdrawn to leave 4 to 6 centimeter in the space. Catheter space is less than 4 centimeter. The increased risk of catheter dislodgement and inadequate analgesia. Threading more catheter increase the likelihood of catheter malposition and complications. These are my references. Thank you.
Thank you, Dr. Rahul. It was an excellent presentation. Madam, please unmute. Lynette, madam.
Unmuted.
Yeah, you are audible, madam. Please.
Thank you, Rahul, for your
Thank you.
presentation. And now the topic is open for discussion.
I think Rahul has covered almost all the areas of epidural needle, and if there is some questions, participants can unmute and ask directly.
Dr. Rahul,
Hi. Hello, sir.
you have presented well. And meniscus sign is a good test for the correct placement. You have mentioned about it. Meniscus sign.
I didn't mention, sir. Actually.
Yeah, it's any comments, madam, about meniscus sign? And another question is, Rahul, when you are removing the catheter, suppose epidural, okay,
Sir.
at the third or fourth day in the postoperative ward or from the postoperative ICU or from the ward, you are not, you are removed the catheter and you see that tip of the catheter has come. It has broken and it's inside.
Okay, sir.
So then what is the protocol?
Sir, reassurance.
Do you think any problem with leaving the catheter tip inside? Your answer is correct. Only reassurance is needed and it won't produce any problem.
Yes, sir.
And in the present scenario with increasing medical legal litigations, you can document it and keep it.
Okay, sir.
Actually, we
Madam,
had one problem.
Yeah,
We had a
madam.
problem in SAT. What
Yeah.
happened was, as the catheter was being removed, it got sheared and then part of it was left. So then we had to talk to the patient's bystander. We had to tell them that this is biologically enough and there is no problem, because they
Yes,
have to be informed, and
Yes,
we
madam.
had to we noted it down. This was years back,
Yeah.
10 years back.
Dr. Alex has given a comment. Dr.
Yeah,
Rahul,
Dr.
you can
Alex
comment.
raised and he can unmute and ask.
Yeah, hello. Can you hear me?
Yes, sir.
Yeah, I'm not able to start the video for some reason. Yeah, hi, I'm Dr. Alex Philip. I work in the UK. Just a very good presentation. Just one comment about what Dr. Rajesh mentioned about the meniscus test. It can be done in two ways. So the meniscus test is where you raise the epidural catheter above the level of insertion and see for the free flow of the liquid column within the epidural catheter. And as an additional confirmation, you can also drop it below the level of insertion to see if blood is coming back. So both will help. And my request to PGs is to try to learn the technique with lots of residual saline rather than with air. Air has multiple problems. I've had personal issues where pneumocuffless was a major issue. Most important point about air, I feel, is that it is not sterile. So you're basically injecting a non-sterile medium into a sterile compartment. So I don't think air should be taught, in my view. And it leads to patchy block because you have these columns of air that build up within the epidural space and prevent the free migration of local anesthetic up and down. So air has more problems than it is worth. And the two problems that you mentioned about saline are not really seen in public in actual practice, because the dilution of the local anesthetic is a very minimal effect that is not seen in practice. And also, if you have an accident pleural puncture, there is no way you will confuse it with the saline, because the force with which the CSF comes back, you cannot mistake it for saline. Saline will not come back with that much force. So in practice, those problems are not seen. So those are the comments I wanted to add.
Thanks.
Thank you, Dr. Alex. And Dr. Baburaj, can you unmute and give your comments?
Yeah, this is regarding ketamine. As you said earlier, ketamine is used for chronic pain management. And many articles have described hepatotoxicity as well as cystitis. When you use ketamine for chronic drug therapy, so it is said that you have to monitor liver enzymes as well as look for the symptoms of cystitis and hematuria. And actually, these symptoms were initially detected in persons who were using ketamine for recreational purpose. So actually, it has been extrapolated, and the research have many articles have come, especially in BMJ and all that. They say something. They even describe something called ketamine bladder syndrome. So, a word of caution when you use ketamine for neuropathic pain. For anesthetics, we need not worry, and somebody has to worry when we are using for neuropathic pain, and also when you are using it for burn dressing and all that. Repeated use. Be cautious. Be cautious.
And regarding ketamine, the pediatrics department is nowadays continuously using to control the seizures, especially when the patient is on ventilator and all. In pediatric patients, they were regularly using ketamine. Previously, they used to ask us, but now they have started using it directly to control the seizures. That's what is happening now. Because they were continuously using, because now they have experienced in managing with the ketamine. Only when it's not resistant to all other drugs, they were using it.
We should inform them that about the raise in the ICP. I think they are not
everything that we have
aware of all this.
Initially, we were discouraging that. But since there are no other options, they were using it. And now they have started using it directly.
Ketamine is a drug. I think it is under narcotic control. And it has to be delivered to the recipient only through writing the prescription. I don't think I never heard that pediatricians using this.
Yes, pediatrics people are regularly using.
I think Dr. Rajesh got a paper with ketamine for controlling seizures. Dr. Rajesh is there? It's true?
Yeah, we got it published in BMJ, BMH Medical Journal.
Your journal.
Yeah, it's an index journal. It's available. Versatility of ketamine. Its title is that. And our one of my colleague, Dr. We had a series of cases for ketamine for intractable epilepsy. And Dr. Jidin, we have presented it in, Dr. Jidin has presented it in the national conference.
Also in ISA Kerala PG update.
ISA Kerala PG update also.
Now, what's the dose that we're using? They were continuously, they were using it as a continuous infusion.
Yeah, that's because they call us for the starting the ketamine infusion. They have a definite regime actually. The neurologist. We get call from the neurologist, not from the pediatric intensivist. Pediatric intensivist, as you said, they are using.
Yes, we don't have a pediatric intensivist, so the pediatric people are directly using it. Well, Leonard, can you have any comments over there?
Well, I have no personal experience on the use of ketamine. What I've read, I have only those kind of experience, not a practical experience on the use of ketamine in pediatrics.
I think there was some more than 10 years. They were have initially they were not getting it directly from the stores, and they were getting it only from our department. But now it's freely available because of the KMSCL production, KMSCL availability. So they were taking it directly and they were using it.
Are they monitoring the patient?
Yes, definitely. They were in the ICU. And also the patient will be in the ventilator. Most of the time, the patient will be in the ventilator. They will manage it. Pediatrics people are very good in managing their patients in ICUs.
They use it for
ICU as well as pediatric ICU. Yeah.
They use it for positioning the patient for LP and all. Pediatricians.
Yeah, for that, I'm not sure.
Yeah, they use it.
No.
I think Babaraj sir wants to add something.
Yeah,
Yes, Babaraj.
even psychiatrists are using. Madam, you will be knowing in Manjeri, our psychiatric
Yes, I
department
know
was
it.
using ketamine. Very
Because,
small dose.
yeah.
It is there in the books, non-anesthetic use of ketamine. It is for
Yes, that
severe
here,
depression. Yeah.
that Rakhi has presented also.
Yeah.
Yeah.
Thank you.
Whether this come under the narcotic rule, this ketamine, because of its misuse.
I don't think so.
Yes.
Yes, it comes under the, you cannot get it over the counter.
Mostly it will be signed by some person who is in charge of that. If it is used left and right.
I don't know what is happening in the private hospitals, but in government hospitals, government medical colleges, they were getting it directly and they were using.
That is because
It's
they're
found to
getting
be
it
really useful also.
Yeah, that is because the KMSL is providing. That is how they are
yes,
getting.
since it is providing it, that's why they were getting it directly. And also not much, maybe in medical colleges, it is available.
And it is one agent which is tried for opioid-free anesthesia also. Intraoperative infusion of ketamine for opioid-free anesthesia, sub-anesthetic dose.
I think ketofol is standard regime nowadays.
Yes, ketofol can be used.
And it in combination with the dexmedetomidine also.
During our PG times, like one of the questions which used to be asked, this for the PGs, regarding the ketamine, it was the non-anesthetic uses of ketamine. And those two answers, what was told to us was, one is for the bronchial asthma and second is for the priapism. I don't know whether it is described in the books now. So these were the questions asked about ketamine. And second thing, I would like to comment on the meniscal sign. If you, there should be some height to which it has to be raised. See, above the insertion site, and there, if you raise it further high, definitely, even if it is not in that space, also there you can appreciate the meniscal sign. So that is also been described.
I think considering the time constraints, shall we wind up the session? Yes. It was an excellent presentation by Dr. Raki and Dr. Rahul. And we should thank Lynette Madam for joining us today evening for this session.
Thank you. Thank you, Vinil. Thank you so much for giving college a chance to present at this platform. Thank you.
Madam's presentation is also coming. Madam has given the topic.
Just two suggestions. One suggestion I have to give to our young postgraduates when you are presenting the slides, the font size should be, I think it is 18 or 16 you had kept. At least it should be 24. Rahul, like what was the font size you had kept?
18, sir.
18.
Yes, sir.
Yeah, it should be at least, if you are presenting, it should be at least 24,
sir.
Not less than 20.
Sir.
Just a small piece of advice.
And before closing the session, one reminder is there. You don't want to announce the ISA Midcon 2022, Dr. Paul. It's
that has been. Yeah, the national president was supposed to announce on that, and that will be ISA Midcon. That will be in Kasaragod, and mainly it will be online only, and it will be on 26th and 27th of March. The details of those will be circulated, and already a pamphlet was circulated, a flyer was circulated earlier. And since all the pages are there, like advise you all to like present papers, etc., and make use of it. Thank you.
Thank you.
Thank you.
Thank you.
Good night.
Good night. Thank you all.
Good night. Thank you.
Lot of thanks. Thank you all for the active participation and making it in a memorable day. And I thank Dr. Mubarak, Dr. Raki, and Dr. Rahul for a wonderful presentation. And I thank all of you for